Hello everyone, thank you for inviting me along. I'm not actually sure how I managed to get here because all I did was submit a paper for another conference you were doing and then got invited to this. So that should say inclusion healthcare, not inclusion homeless, although I will be talking a little bit about homelessness as well in terms of what we do at inclusion. Feel free to ask me any questions because I do tend to ramble a bit. Okay. So I'll introduce myself. I'm Wayne Henderson. I've got several different roles within inside Inclusion Healthcare. Inclusion Healthcare are a community interest company which set up in 2010. Prior to that, we were a direct managed GP practice providing primary healthcare for homeless people in Leicester. I'm a director, but my professional role is a mental health nurse. And I do substance misuse with homeless people and mental health support with asylum seekers. Okay. Right. So that's just a little oversight of who we are and why we exist. We're there. We focus mainly on marginalised groups. That's our group of people we want to support. Anyone who we feel is excluded from mainstream services and has been excluded, we try and improve their health and well-being in Leicester. So these are values which we recently redid. So probably all of you have similar values and stuff. We use these for any decision making we make regarding the provision of anything we do, any steps we make. We have an executive board and non-exec board, and we use these to kind of measure any decisions we make going forward in kind of what we want to deliver, any big contracts even, or small steps we want to do. This is what we measure everything against. And obviously the motivation for this is, as you know, in poverty and deprivation, people often have far more health needs, and those can be exacerbated by unable or lack of ability to access healthcare services. So where it all started. Some people may have seen this doctor. This is Dr. Nigel Hewitt. He was a GP in Leicester. He worked in a very affluent GP surgery in the 90s. Noticed there was a need for homelessness. He was doing kind of drop-in clinics at hostels, kept pursuing, it wasn't the ICB back then, whatever it was in the 90s, whatever form it was, and managed to get them to fund a practice for homelessness, which came online, basically started about 2000. And then, like I say, in 2010, this is Dr. Anna Hiley. She then took over the kind of CEO role from Nigel when we became a community interest company. I think, one of the reasons we wanted to become a kind of community interest company and not be directly managed is because they restricted us from doing things. We wanted to kind of branch out and do more and help more groups, so it was in the best interest to kind of look beyond what we got at that time. And I don't know, some of you may recall around about the early years of the Labour government at that time were pushing to get social enterprises involved in provision of healthcare, and we were chosen to be one of the pathfinders of looking to do that. We did a year working alongside that to then get turned down by our CCG at the time. They didn't want to do it, but came back to us about 18 months later and asked us to become a social enterprise because there was a fear that a small practice like ours would get taken over by an unscrupulous healthcare provider. We provide, let's say, 2 practices on the APMS contracts. This is our current building, Charlesbury House. It's an old schoolhouse next to a church. It's quite good because we've gone full circle. This was built in the 18th century to support poor children in the area. The area in which we're situated back in those days was a big area of deprivation. This schoolhouse was built by the church next door. Before we took it over, it was an insurance building, so it's kind of gone full circle that we're now providing support for people from deprived areas. The 2 practices we run the inclusion practice, which is basically the homeless practice. That started, like I say, in 2000. we had two GPs, which were Nigel and Anna. They shared the role. We had one practice nurse, one practice manager who was in the building, the other side of town, and one receptionist who would go around the different venues where we were doing clinics and act as a receptionist. We provided most of our sessions at that time from hostels or day centres. So this was the old night shelter in Leicester. This was the Anchor Centre, which was a wet centre for street drinkers. I'll talk a little bit about that later on. And this was the old YMCA day centre. So they were our key places where we provided services from in the early years. We walk around with a little trolley, computer and laptop and just take everything around town before GDPR took over and you couldn't take anything anywhere with you. And kind of this is a little progression. So in 2006, Leicester City Council built the Dawn Centre, which was a multi-agency building. Half of it was accommodation, had rooms for 46 people. This half here was a multi-agency part of it. At the time, all this bottom floor was ours and had 6 clinic rooms in it, purposely built, and our admin was on the first floor. So, but that we got there in 2006. We started to outgrow it quite quickly. When we became a social enterprise, we expanded very quickly, really, in terms of what we could do, and we outgrew the building. They couldn't give us any more space, so this is when we moved to Charlesbury House. And these are our 3 CEOs we've had. So Dr. Hewitt, Dr. Hiley, and our current one is Dr. Stiles. So the assist practice is our asylum practice. Leicester Leicester's a dispersal city, so it's had asylum seekers for over 20 years. It originally, because they were all placed in this massive old hotel called the International Hotel in Leicester, and they recognised the need for primary healthcare for them. They again commissioned a primary healthcare service for asylum seekers, which was in a very dingy building opposite, really dingy. The windows were about that big at the top of each room. That was it. It was just a long corridor with 4 rooms. And so when we got asked to take over the assist practice in 2016, because the providers, who one of these unscrupulous money-making health providers, decided to ditch the contract and left. So we had expressed an interest in running that service previously, but because of our infancy as a community interest company, we didn't have the financial background to be able to apply for it, so it was turned down. But the CCG at the time came and asked us to look after it, take over it for an interim period, which we did. When we moved into it, we found that it had been terribly run, basically by just locum GPs who did everything on this is all I got to do today and go. So we had to invest a lot of time into getting it to a standard where we felt it was safe to continue to practice. And then we won the contract in 2018 when both that and the homeless contract went out for a retender. So since 2018 we've been running it as full contracts. And in 2019 we moved it from the dingy building into our nice kind of churchy school building. And we have both communities come into one building. There was a lot of thought about how they would get on together. And to be honest, we've never had one conflict between a homeless patient and an asylum seeker patient. In fact, they're very courteous to each other, very courteous, very supportive of each other's needs, and you wouldn't know the difference when you go in there in terms of how they interact with each other. Okay, so I didn't tell you. In the homeless practice, we have about 850 registered list size. Obviously, they're not all on the streets. We haven't got 850 people sleeping rough in Leicester. So our homeless practice will accept anyone who declares that they're homeless in whatever form. We don't ask for any proof. If we later find out that they are kind of accommodating and stuff, we will ask them to move on to a different practice. We are only allowed to register homeless people. As with assist practice, the asylum practice, we have about 1,600 patients currently registered. The majority of them are in mass accommodation in Leicester. Post-COVID, when the kind of Home Office closed down a bit and numbers shot up and have subsequently continued to shot up, our numbers rate went up to beyond 1900, which became actually unsafe to manage. We had to close the list for a short period of time to kind of find out why we got so many. And basically, even though we were aware that Home Office were making lots of decisions, our list size wasn't going down. And part of that is Serco won't share the information. Although we have a rather good working relationship with Serco, we provide the NAS accommodation, they don't share information with us about people moving on, so we never got to know anyone who moved on. And some of the other partner agencies who were supporting asylum seekers also weren't letting us know that people who had remained in the area but had got status hadn't, weren't letting us know, so we could ask them to move on. Again, we're only supposed to have people who are actively seeking asylum.
So what's Serco?
Serco.
Very basic question.
Serco, what are they? They're the providers who, it was the old G4, remember G4S? G4S used to run G4S used to run all the national asylum accommodation. Yeah, well it just went to Serco.
Oh.
So Serco do the same thing as G4S, which is just as poor really, but so pardon?
So currently, in say the asylum seeker practice, so do you just have a rotating salary? Who are the GPs then?
So we have each practice has, well, the homeless practice, because of the numbers, it gets one whole-time equivalent, but we have one main GP who provides about 5 sessions a week, and then we have 2 or 3 other GPs who provide people. We have a whole list of GPs actually who are all interested in working with us, and they're all salaried. So on the asylum side, we'll have again one main GP who does the bulk of the sessions, and then we've got a pot of 3 or 4 who come in and will do a session or 2 sessions, or they'll do a session from each side. We kind of build up a list of doctors who are interested in the area, so we kind of start. We very rarely use locums. We try not to use locums. We always planning far in advance for annual leave cover and that. So I think we've got one regular locum who's been with us for many years, who does a few sessions, but generally we try and get people onto salaried roles and offer them regular work, constant sessions and stuff like that. And like I say, if anyone wants us to have an interest in working for us, we'll invite them along. If they want to kind of join our list of backups, we'll often give them a sit-in session, pay for them to have a sit-in session, to sit with the GPs, to see if they like it and enjoy it, and then put them on a list, and then if anything pops up, we'll just keep inviting them in. So we tend to have quite a lot of interest. We never struggle to get a doctor, if I'm honest. We've always been able to fill the roles quite easily, and they tend to stay with us for a long time, so we don't have that much movement, usually retirement. Yep. No. No. The reason I do mental health support is because there is no mental health support. Most of my career with inclusion has been with homeless. Around about 2019, when we took over the full contract, it was identified the number of GP appointments being taken up by mental health issues, and as a director, I sat in the exec team as we were talking, and the APMS lead was talking, and suddenly all eyes were on me as if to go, Wayne, would you mind supporting our mental health needs? So I do 3 sessions a week of basically holding. I don't do counselling, I don't do trauma and stuff like that. I'm not a specialist in asylum seeker healthcare or mental health. I just hold, try and get them to think about the situation differently, try and motivate them to do things and stuff like that. Because I know with asylum seekers we talk a lot about trauma, and everyone thinks it's all about trauma. The trauma is now, while they're in the process. What happened, is something which needs to be supported, but actually the trauma they're in is now. It's just as traumatic. They're still imprisoned to an extent. They're still restricted. They're not allowed to do all the things they've fled, you now get again in this country. So my kind of role is to try and keep people safe. As a prescriber, I carry on any medications which have been commenced, and really just try and connect them with whatever's available out there to try and get them to make the days better. You know, it's never going to get better until they get the decision, and hopefully it's a positive one.
What's the
But then
average length of time
for
getting
status,
Yeah.
it varies dramatically. We've got people who've been waiting 10 years plus. We've got people who have come in and they'll get it. You know, the government currently picks which countries get prioritised. So in Leicester over the last 8 months, 8, 9, no, probably longer. Probably getting on for they said they were going to do 1,000 decisions in Leicester before Christmas, and that was from October to Christmas. They were going to make 1,000 decisions. They didn't, fortunately. They only made about 400. That was fortunate because it has an impact on the homeless side. The asylum seeker, the amount of asylum seekers getting leave to remain is now impacting upon homelessness. There's a big crossover at the moment between both practices for us and how we deliver care for those people who ex-asylum seekers who then become homeless. It's not your traditional homeless person. The needs are very different. And our services are very different. The homeless service is one of grab them, bring them in, kicking and screaming, whatever you can do, you get them to you. The asylum seeker is, without sounding bad, hold back the door because you cannot provide enough. The more you provide, the more they come in. We provide, I think, nearly 50% more GP appointments than what is required under our KPIs for asylum seekers because the demand is so great. And the language barriers. Every appointment is a double appointment because you're having to use language lines. So you half your appointment, so you've got to kind of add appointments in to be able to talk to people. It's always, a session could be 12 appointments, but you actually, in the end, you're only having 6 appointments because it's all doubled up. Yep.
You said that they had suggested that they would make 1,000 decisions in that time period before Christmas. And from your perspective, fortunately, you made 400. But what were the barriers to them not making more?
I would say the Home Office, the incompetence of the Home Office. Without being rude, it's just the incompetence of the Home Office. They are just a terrible service to work with.
Was there any,
No one works for the Home Office here, do they? I wasn't really saying that.
was there any suggestion that the number of tribunals that they could hold was restricted?
No. Most people, if they've been declined, and they've been in touch with the British Red Cross or Migrant Help, will get the appeal process. When someone gets declined, the main concern is their accommodation initially, because as soon as they get declined, they're going to be kicked out. So you have to get that. That's your priority to get sorted out first, and then once that bit's been sorted out, Section 5 been sorted out, then they get their accommodation stabilised. They can then go through the whole appeal process.
I have a couple of questions.
Yep.
One is that I work in an immigration service in Salford, and we also see a lot of people who are asylum seekers and refugees. And as you said, that holding thing that you do, I find that I do that quite a lot, and I'm sure a lot of people here do as well. Do you have any tips, resources, things that you looked at because you said that that's not what you're trained in?
I think I just use life experiences really. Like I say, I think it was over 50% of the appointments were taken for GPs were taken with mental health, and it was repetitive. It wasn't it's a small group of people. So my caseload is about 60 out of the 1,600. The GPs still see people for depression and mild anxiety and stuff. We are fortunate that we have the ICB did commission a specialist mental health worker who works with people with kind of existing mental health issues who then get exacerbated by something, and she can offer them 10 extra sessions of she's very experienced, has worked in asylum mental health for 20 plus years, and she will do some trauma-informed stuff and all that. But for me, it was like, I think, for example, we had one individual, he used to turn up at least twice a week to see the doctor. His issues would be physical, mental. It was all linked in to being unhappy in this situation. He'd just keep coming back wanting something. I took him on. It took a bit of education, with the GPs to say, do not talk about mental health with him. If he's come for a physical problem, obviously, but if it's mental health, defer him to me. Do not get into a conversation about it. And I offer them all follow-up appointments. So everyone who comes under my care gets an ongoing follow-up appointment. So you've always got something to direct them to. And I think that knowing that they've got someone to talk to helps. And that guy I was talking about, I should have put him on a case study really. He presented to A&E in the 18 months before I worked for him. He had presented to A&E on about 12 occasions. He'd had something like about 60 appointments with the GP. In the 18 months after when I worked with him, he'd only presented to A&E twice, and he'd only had about a dozen GP appointments. And to be honest, most of those I would have arranged for him to be reviewed and stuff. So I wasn't really doing it. It was just giving him something to know he'd got time to talk to, know he could ring me if he needed any additional support and stuff like that. And that's really kind of and it does seem to work.
The other thing I just wanted to ask was about, I suppose, like fronting hours, because I find a lot of it is with these patients, it takes a long time because their needs are complex. There's a lot of mental health issues in between physical, and you need an interpreter. And then at the end of it, it's like helping people navigate all the different services and the different things from the access. So, in the infusion service, we have just about enough time to be able to get there. In the mainstream, where we still have lots of those patients who don't have the time, and we still manage to try to do as much, but you find that when we then have to just direct them to reception to do things, our mainstream staff is don't have.
Well, I mean, it's a bit of a double-edged sword, isn't it? Having a specialist service in your city is a bit of a double-edged sword because people, asylum seekers don't have to register with us. Most of the ones we have are generally in NAS accommodation, so they come through that route to get directed to us. But obviously Leicester has a very multicultural background. I know the GP practices of asylum seekers practice, registered with them. They're probably the ones living with family members or can afford accommodation or whatever. But I know also when we had to close our books for a few months to try and get the numbers back down to manageable, it soon came back that mainstream GPs would not accept asylum seekers because we've got an asylum seeker practice. So even though we weren't funded for the amount of patients we got, they still expected to see it. Strangely enough, in 2018 when we were bidding for these, a lot of mainstream practices didn't want to have an asylum seeker practice because we do get paid a bit more per patient, and they were saying if we got paid that much, we could do this as well, we could do that. So they didn't want us, but then strangely COVID worked in our favour because of the influx. Leicester capacity, basically the Home Office dumped on Leicester with all ours were in NAS accommodation. During COVID, they opened up 3-4 hotels in Leicester. 3 of them are still full. So we've still got like 400 people in hotels in Leicester who are asylum seekers.
So what, when you're offering support, so you took them from 60 appointments down to 12 GP, how long were you spending with them each week? And what?
How long each week? Or
would you need a mental health? You obviously got a mental health background. Was it your mental health background or your life experience and just spending time with them that they had another route? What was it about that appointment with you?
The appointment is first identifying. I can basically summarise. If I say out of my 60 people, I've probably got half a dozen who I would say have mental ill health, proper mental illness which requires secondary care support. The vast majority are just bored. Bored. It's not met their expectations. They're
Doesn't mean I know.
Yeah, and that's it. It's just like, it's trying to motivate people to do something more. You do get people who some of the past trauma is impacting upon them, and I can refer them on to appropriate services to get on a few. But our waiting list for kind of therapies, if you want CBT, you're talking 18 months to 2 years wait just to get it. If you want psychotherapy, it's nearly 3 years for psychotherapy support. And our cut-off point for community mental health team, well, you may as well not bother. So it's kind of, yeah.
How long were you spending with them?
Each time I spend 30 minutes usually. So it's 15-minute appointment. All our GP appointments are 15 minutes, but then we double up. I mean, there is a couple of patients who I know will talk a lot more, take a bit more pushing out the door. I'll allocate a bit more time to, but as a rule, it's normally about 30 minutes I spend. And part of that is because I have to use an interpreter for probably 95% of the people I'm talking to. So this is part of our team. You may notice this was taken during COVID, so we were celebrating our 10-year anniversary when COVID kicked off, and we tried to get a group photo. So we had to use our car park and spread as many people out find a window where we could look down. But basically, we provide everything every other GP service provides. It's just probably how we provide it slightly differently. We do have specialist midwives who come in to do both the homeless and the asylum seekers. So we have a day a week when from the midwifery team we have 2 midwives come in who will support anyone who's pregnant. We have very close connections with Hep C because of the homeless side. Should put on there now TB. We're doing a lot of work with TB at the moment. We're supporting some pilot scheme that we're doing a few months ago, and they had to stop us from doing it because we were causing them too much work in finding people. Because screening new arrivals, we're just finding so many people. It's an ever-changing situation. We are part of a PCN, but because of our numbers, we don't get very much from a PCN kind of support. So we've got social prescriber, but we get one morning every 2 weeks to do social prescribing for both practices. And when you work in a specialist area, they know less than what we know in terms of that kind of aspect of things. So this is I'll quickly talk you through a patient journey. So this is our lovely entrance to the building. We walk up the corridor, obviously. We do everything on the day. So not everything. We do have some pre-bookable, some special appointments. But we try and do everything on the day so that it's a first come, first serve. Slightly different, due to the demand of asylum seekers, they're there from we open our doors at 8 o'clock. They're there from 7:30 waiting. That did have an impact on the homeless people because they're not prepared to wait. So we've had to adjust the times a little bit. So we open 8 o'clock for asylum seekers. We deal with the kind of mass at the beginning, and then we start accepting appointments for homeless from 8:30, and that's worked out a lot better. So we have 15-20 minutes of chaos, and it's like say at reception, language barriers, people wanting to register, lots of things. Trying to get all that sorted can be very frustrating. So this is one of our receptions. This is a kind of our assist reception currently. Through this door there's another reception which we use for homeless. So we have 2 receptions running each day. You see the photos were taken during COVID with measles. This is our clinical area. So we have 3 wings. One wing is dedicated for asylum seekers, 1 wing for homeless, and then we've got what we call a soft area where we do the kind of drug treatment, mental health stuff, and other visiting agencies can come in and use. And I would say none of it works without partnerships. We're only as good as our partners. If there's one thing to get along, everything we've done, we do with the partners. So we're very well connected to the council, the police, drug treatments, everything, all the third sector support. We rely on them to do most of our job, really, is getting them to the appointments, sharing the information, stuff like that. So ours is probably the easier bit. Once they're there, and or trying to advise them how to get there and stuff. And going back to what you said about signposting to people, I think a large part of what we do with asylum seekers is educate them into services, how to use services appropriately, how they work, where you should go. A GP is unknown to them. They don't know what it means. Wild expectations, but that's it. The partnership is the key thing. And now put this in Leicester Homelessness Charter again. Partnership working that came around in 2018, and that was as homelessness was starting to rise. And that was inspired by Manchester and the Manchester Homelessness Charter, which you were the first in the country to set up. So we followed suit. I think we did a visit and followed suit and kind of introduced a charter which we have now, which is still running today. And multi-agency meetings, we have many of those. Not so many on the asylum seeker side, unfortunately. There's just not enough support for asylum seekers. There's lots of support for homelessness. Well, in Leicester, there's lots of support, and there's a better network nationally for homelessness. But asylum seekers, I think we're one of the only few practices or few cities which has a specific service which is totally dedicated to asylum seekers. There's very few.
Is there not like any local charities? Like I've got a friend in Birmingham, which is part of
Yeah.
Calvary, which is it is a church-based. I can't remember the proper
Yeah.
structure, but she's literally someone who does the hand holding while they're waiting for their asylum to be
Yeah,
processed.
we've got City of Sanctuary,
Right.
which are a national charity. They're based in Leicester, and that's the one I would refer for activities. And so they have close links with Leicester City Football Club, who provide football sessions at the weekend for asylum seekers. They're our main ones. There's a few other little ones, but compared to homelessness, it doesn't bear. It's not the same. And meetings-wise, these are all kind of homeless meetings. I only attend a couple of asylum seeker meetings, and they're normally multi-agency ones about the issues it's causing to the city in terms of demand.
How it can sometimes help with coding, so you can take someone's introductory or something
Yeah.
like that. In our practice, we're not specialist practitioners, we coding someone's asylum seeker or
Yep.
codes to
We do that, yeah. So I mean, obviously, people, if they register, they kind of assume they're one or the other, but we do code it because for the search and needs assessment and things like that, and we do try and promote that when we go out to other places. The importance of coding, so that when people come out to do needs assessment, you can pull out that data. It may not seem relevant at the time, but it is worth doing. Just having a code which is used widely to be able to do. And I know I'm nearly there. Well, I don't know. Tips for starting up, basically. Needs assessments. Work with your partners who know what's happening. Lived experience, you can't talk enough about it. It's widely used in homelessness. We're trying to get it into asylum seekers as well, to get asylum seekers engaged in supporting our people who are going through that process. But City of Sanctuary use lived experience all the time. Most of their volunteers are currently in the asylum process. And obviously you probably know about engaging with hard to reach communities. What we say we do not have a one problem, one appointment system. As much as that can be to our detriment, what we try to do is deal with everything we can on the day, and educate people how to do it better the next time. Right, I was going to say, this is what I was supposed to talk about, but thank you. Thank you very much.
Thank you.